so lots and lots of information thrown your way, and I'm just gonna throw some more, because why not? You're here, and I appreciate your attention just for a little while longer. So let's talk a little bit about the actual OICM hip fracture program and our system planning for improved care, because that really is the most important part, and this is the meat and potatoes of the program. So why a formalized program? Currently, and I've been told that this number is probably lower than it truly is, we see about 350,000 hip fractures annually nationally, not us at Central Maine, but nationally. And we are in an aging population. So by 2050, there is approximated to be 650,000 hip fractures annually. Again, the 80% female, that is the most common, past 80 years of age is the most common age that we see. And women have a 1 in 7 lifetime chance, which is greater than breast cancer. So pretty significant. We have based our program off of the St. Francis Hospital OFC, and that's in South Carolina. And again, I love stats, so you can see here some of the stats, the program stats that they have done pre-program and post-program. And you can review those, but as we stated, ED to incision is one of the most important things that we can do for the patient. Length of stay, we don't want them laying around, and then of course we always look at cost. So their outcomes, post, 80% of their patients return to independent living. These are really significant outcomes since when they started their program. Their mortality rate is less than 20%. Post-op delirium less than 4%, a great infection rate of less than 1%, and 100% patient satisfaction, which for Diane and I is one of the most important things. So our current metrics, from July of last year to February of this year, we have seen 86 hip fractures, which we hope to increase with your assistance. Our ED to floor time is 4.52, and our goal is less than 4 hours, so we're well on our way. ED to OR, 49 out of 86 cases was 22.18 hours. So we're starting with a goal of less than 24 hours from ED to incision, and we're meeting it currently. We want to get even less than that. If you remember, I said our motto is that we're never satisfied. Just because we set ourselves at 24, when we beat that, we're gonna set another goal lower. Our mortality rate, we haven't been able to track overall within a year, but we're working on getting that metric, and that 1.2% is in-house, so during their hospital stay out of the 86 cases. Post-op delirium rate 3.5, and discharge to home, we have some work to do, 14%. But we are always working on these metrics. So this is kind of our clinical pathway, if you will, and it does start with you guys. And as Rich said, it's so important. The information that you can get to us when you bring these folks in is of the utmost importance in starting their journey out on the right foot. So patient arrives in the ER. This is where we have standardized our order sets. So there's an order set for the ER to admit the patient, and then they get in touch with the orthopedist and the hospitalist, and that's where the discharge plan begins, as Diane stated. They get admitted to M2, Memorial Wing, 2nd floor, which is also called the OICM. Hospitalist consults and clears, prepares for surgery within 24 hours or less, and so there is another standardized order set. So the on-call doc isn't picking and choosing what they want to order for these patients. We've done best practice research, and we've put together standard sets for patient care. Hospitalist follows the patient throughout their entire stay, so they don't just do the clearance for surgery and then don't ever see them again, because as you've heard, these patients have a lot of medical conditions and a lot of potential medical risk factors post-operatively. Discharge planning, always important, and that continues on. And then the patient is discharged, preferably to home with home health, but we do have patients going to rehab, skilled facilities, and then they need to follow up with Central Maine Orthopedics as well. We do have a program vision. We want to be best in class. We want to develop a center of superior performance for hip fractures. Again, that is focused on the multi-specialty team approach, delivering value and quality through reducing variation. And reducing variation means we're using those standard order sets that are based on best practice. Here's a list of our goals, some of which I have mentioned with the time frames, but we also want to enhance their functional outcomes, reduce the nursing home placements, increase patient and family satisfaction. Another one of our big things that Diane mentioned, we have put together patient education, patient and family education for our hip fracture patients, and they will receive that right on admission. And that has been created by our own multidisciplinary team. And we really want to become, and we will become, the first formalized hip fracture program in the state of Maine. So there is not one currently, and we're here to tell you that we're going to be the first. It's a very exciting time for us. We've been working about 3 years on getting everything in place to make sure that this was right for the patients that we were going to bring in. So this lists some of our success strategies, which when reading over them, I hope you've been able to hear throughout our presentation. We're working on things such as reserved OR time. There's a big OR initiative going on in our organization, and we're working with them on that. We do have dedicated beds on the orthopedic unit, and they are all telemetry capable, and that's another important part. We designed our unit 5 years ago, all private rooms, very aesthetically pleasing, very hotel-like, and they all have telemetry capability. And that's important, especially for these type of patients with the medical conditions that they may have. We do aggressive therapy. We've trained our nurses and our CNAs and our therapists to not be nice and say, yes, you have to get out of bed. It is day of surgery, but we need you to get moving. It's gonna only benefit you in the end. And then again, early discharge planning, and we always will look at our outcomes. We're always gonna be pulling our continual outcomes and making changes based on what the numbers are telling us. So in summary, preventing hip fractures and their causes, as Dr. Gumati stated, is a really important step. And I did forget to mention too, part of this hip fracture program isn't just about taking care of them after, but it's about the prevention part, which actually needs to start well before they're middle-aged. It needs to start actually in the elementary schools. So I would actually like to see some of my nursing staff getting out into the elementary schools and the grade schools, high schools, and talking about osteoporosis and prevention and nutrition. So that'll be another component of our hip fracture program once we get things more solidified. Hip fractures are common, they're debilitating. Our goals of treatment are to limit pain and help the patient return to normal activities. Caring for these patients, it does require knowledge of the pathophysiology of various hip fractures, and that's what we have the surgeons for. And then developing a hip fracture program at the Orthopedic Institute will help to reduce complications and generate better outcomes for our patients. So with all of that information, I would really encourage you all to take this back to your peers, in your work settings, in your communities, to your friends and families, and just talk about it, because it is important. And we've done a lot of work, put a lot of work in place to make sure that these patients get the optimal care.